rise to be able to talk to this body again about health care, the cost of health care. This has been an issue that's been an ongoing dialogue for a long time around the Senate and around Congress. It's an issue that was supposedly settled when the Affordable Care Act was passed, but ironically enough, my Democratic colleagues have now joined Republicans in saying that they want to repeal and replace the Affordable Care Act. They're not using the term repeal and replace, they're just saying they want to do Medicare for all, and built into that is completely taking out the Affordable Care Act and replacing it with something different. So we're ironically on the same spot in some ways, that we both realize, and we both come to the same spot, that the Affordable Care Act didn't pass. And it actually did pass, but it's not working. So the challenge now is what to do with health care. So we're trying to be able to break into pieces now what we can actually do together to be able to get this done, beginning with the costs on prescription drugs. I continue to hear from Oklahomans all over the state about how hard it is to be able to deal with the costs in prescription drugs, how rapidly the costs are increasing, and how sporadic the cost changes really are. They'll have a drug that costs a small amount 1 month and come back a month later and find a dramatic increase for the exact same drug. They can go pharmacy to pharmacy and find a different price for the exact same drug, or find the pharmacy that's closest to them doesn't offer that drug. A different pharmacy is the only one that's allowed to have that drug, and the complexity is driving them crazy, rightfully so. We're finding as we peel back the layers on pharmacy issues that the complexity is being built in to hide cost overruns. For the past few months, we've looked at every step in the drug process, from the approval to research development to trying to figure out how it's actually getting to the consumer and the costs. Along the path, several things have occurred. The administration has aggressively been approving generics. In fact, the administration has approved a record number of generics. Those generic pharmaceuticals are much less expensive than the branded pharmaceuticals, and many of those have been waiting a very long time at the Food and Drug Administration to actually be approved. The Food and Drug Administration is rapidly getting those out the door. That helps consumers. Something else we've done in Congress is try to address something called the gag clause. The gag clause is one of those things that was just behind the scenes that no one knew, but the pharmacist knew. Because if you came in with your insurance card to pick up your prescription, the pharmacist knew the actual cost that you would pay if you paid in cash. And often you could get that same prescription paying cash less than you could with your insurance card. But the pharmacist was prohibited from actually telling you that. We in Congress have addressed that in a bipartisan way to be able to release that gag clause and allow pharmacists to be able to actually tell people their options on pricing. Now, you should say that is an absolutely crazy thing. Who put that gag rule in it? Well, the system and the structure behind the scenes that negotiates all of it said if you want to be a pharmacy that sells these drugs, you have to submit to these rules. Culprit behind many of these issues, as we found, is a group called the Pharmacy Benefit Managers. You'll hear it called just the PBMs. Those pharmacy benefit managers are supposed to negotiate between the manufacturers and the insurance plans to lower the prices. And in many areas, they have lowered prices. But they've also given preferred formulary placement to some of their preferred pharmacies so that some pharmacies get that drug and other pharmacies that are competing with them don't get access to that drug. And often it is the drug that is the highest margin drug only their pharmacies will get and other pharmacies will not. It's become an anti-competitive piece in the background when it was supposed to be something that was a highly competitive piece to be able to actually help the consumer. Unfortunately, PBMs have created one of the most elaborate, complex, and opaque system of pricing, which has a tremendous amount of market distortion and at times has limited patients' access to those drugs. It's a system that they've been able to take advantage of and that create financial incentives to be able to help their bottom line in the process rather than to actually help the consumer oftentimes. And the rebates that many consumers have heard about, that they wonder who is getting rebate, they go to be able to pay for their pharmacy pickup and they're not getting a rebate, but there is a rebate going somewhere, just not to them. So here's the challenge. We're trying to be able to peel back with greater transparency what is happening in the pharmacy benefit manager world and how a small group, it's actually 3 companies, have 90% of the market nationwide for pharmacy benefit managers, how that middleman in the process actually handles pricing and negotiation. If you talk to any pharmacist that's an independent pharmacist anywhere in the country, and certainly across my great state, they'll all express their frustration with pharmacy benefit managers and their access to some drugs, not to others, and the stipulations that they put there deliberately to be able to hurt them, to be able to help others. I've joined my colleague, Senator Cantwell, in trying to shine some light in the operations of PBMs within the drug chains. Consumers deserve greater transparency. That will help us understand the actual cost of drugs and how those costs are actually getting to consumers or not to consumers in the process. The PBMs need greater examination, and we're finally taking that up to be able to walk through the process. On the Finance Committee, we're dealing with several issues. Led by Senator Grassley, we're walking through Part B of Medicare, Part D of Medicare, and trying to be able to examine what can be done to be able to help the actual consumers. Our goal is, how do we actually increase the options in drugs that are out there? How do we stop the cost increases? And how do we decrease out-of-pocket costs for pharmaceuticals? In Part B, these are drugs that are often intravenous, but they're done in a hospital setting or an inpatient setting. As we're working through that process, we're trying to find the perverse incentives that are built in. Because right now, physicians are actually paid a percentage of the medicine that they prescribe in Part B. That means if there are 3 medications that are out there, if a doctor prescribes the highest cost medication, they get a much higher reimbursement. It's not a flat amount. Now, all 3 may be intravenous, but whichever one is the most expensive actually helps the doctor the most. Now, I'm not challenging doctors and saying they're always prescribing the branded drug in the most expensive in the process. That's between the doctor and the patient to determine. But there is no doubt a perverse incentive built into this that if they prescribe a more expensive drug, the doctor in his office actually benefit from it. We need to be able to fix that. In Part D, there are reforms that can actually slow the growth in cost increases and allow people to have greater access to drugs. We're not interested in some kind of formula where we're actually going to decrease the options to patients of what drugs that they can actually get to in their formulary. That's the great thing about being an American, is that we don't have limited formularies. It's very open in the process so that Americans can try different pharmaceuticals and to see which one works best for them. That is not chosen by government, it's chosen by them and their doctors. But the Part D definitely needs a redesign of the benefit structure. Because right now, things like the donut hole drive up costs for consumers. But there is a way that we're exploring to be able to limit the out-of-pocket costs for beneficiaries, so that there is a lifetime cap that's sitting out there. There's an opportunity to know that I'm not going to, if I end up with cancer or some other rare disease, that I'm going to have this out-of-control cost on the pharmaceutical side. Or to be able to know that there's a donut hole waiting for me when I get a couple of $1,000s in, I'm suddenly going to have very expensive times, so I can afford my insurance in January, February, and March, but in April to August, I can't afford prescriptions anymore. We can't have that. We've got to address those issues because that dramatically affects the out-of-pocket costs. There are lots of other options that we're working through this process, like the rebates, as I mentioned before, actually getting to the consumer, not to the companies behind the scenes. Dealing with how to get greater advantage with biosimilar drugs, very similar to the generic drugs, just in a different category, a reduced cost, but allow them to be able to have opportunities to be able to get to those drugs faster. We've got to deal with some of the patent issues to be able to make sure that drug manufacturers can't hold on to their packets, their patents abnormally long, and so that generics can't actually get out to people, or to be able to bundle them together to be able to restrict their patents. We've got to end this practice of surprise medical bills. Some folks have no idea what that is, and other folks know all too well. They looked in their insurance, they went to the hospital, they saw this hospital is in network, they saw their doctor was in network, they go to the hospital in network, they go to the doctor in network, but they get some giant bill from an out-of-network anesthesiologist, or the lab was out of network, though the hospital's in network, and so they get a giant bill from the lab. We're working to be able to end that practice of having labs that are out of network or certain specialists that a doctor has sent them to, that the patient assumed they were in network, but then they find out that certain individuals that have taken care of them there are out of network and much larger. We're also dealing with the issue of air ambulance surprise bills, which has been a great challenge to those folks in rural America, that they're having to be transferred long distances to be able to get to a hospital and then get an enormous bill for an out-of-network air ambulance as a surprise billing. There are ways that we can address this to be able to deal with the out-of-pocket costs, and we're focused on areas where we can find agreement and things that we can do to be able to work through this process. There is much to be done, but the area of prescription drugs and the area around in-network, out-of-network, and surprise medical bills are areas where we should be able to find common ground. And I'm grateful that I'm part of this dialogue to be able to help try to find ways that we can bring us together, get this resolved, and get a better situation for American consumers and patients in the days ahead. With that, Mr. President, I yield back.